Hello, good afternoon. I will start off from here, and then we'll join my companions there. This is the last. This is the last session in the afternoon, and we're trying to project the future of value-based healthcare in Portugal. They asked me to make a 5 minutes, will be less, introduction on the topic, and I will make a few statements and cut a bit of the history of value-based healthcare implementation in Portugal. Well, healthcare is in crisis. This comes as no surprise, and it's not only in Portugal, it's in crisis globally. Now, therefore, we need to change. A big reform that is not linked to the traditional discussion public versus private, or it's not only grounded on medical technologies, but on a new model of providing, managing, and reimbursement and paying. Following on the steps of Michael Porter some 12 years ago, when he claimed that he would fix the healthcare system, which of course he did not. This is far easier to accept as an inspiring philosophy than to implement it practically. And I know exactly what I'm saying. In Portugal, I think back to 2018, Pedro Pitabarres and myself hosted the first ICHOM meeting in Lisbon Novus Rectory. And this was a 2-day meeting, which sort of banged everybody relating to this new emerging concept. Now, after that, Health Cluster championed different projects. Ophthalmology with Murta in Coimbra, Oncology Institute in Oporto, CUF, Luz Saúde, all adopted value health care strategies for local areas of care. In the meantime, we created a collab, Value for Health, that was a tool to enable and facilitate implementation at the provider's level. Last year, again, Nova Business School, we hosted, which was the first ICHOM TDABC consortium meeting globally. And this showed a movement, a new trend regarding value-based healthcare. Now, the way Value for Health is being implemented globally in Portugal is following some ICHOM standard sets recommendations. And we pick among different pathologies which makes part of the burden of disease, and we just bank on outcomes and patient-reported outcomes. This is good, but it is slow. It is too slow, and I would say I'm not very optimistic that following this path, we should take longer to achieve something real. Now, having in mind that value is an equation with outcomes in numerator and costs in the denominator, it looks like that analysis-based costing, TDABC, is a fundamental part for value introduction. And as a consequence, ICHOM has recently turned to cost analysis. And this is something we can really feel. And this is possibly the way to go. And the World Forum in January this year produced a detailed report focused on payments, value-based payments. I think paying is more attractive than just measuring outcomes. Outcomes is nice. For me, I'm a cardiac surgeon, and risk management and evaluation of data came from cardiac surgery. And I will leave the public system in this country on the 7th of July. You may write down on your agenda. And I'm producing a book from my unit in Santa Marta, in which I'm reviewing 15 years of activity with outcomes, length of stays, costs, predicted costs. So I was able to do that. It will be by Almedina. I was able to do that because we have data. So data is really important. But if you want to get things moving, we need someone paying. So new payment models for healthcare that are based on outcomes rather than classically in volume of procedure or mere GDH, so diagnostic groups, might be an effective way to implement value-based healthcare. In order to proceed, there are several conditions and to finalize that I think are important. Every player and stakeholder need to be involved and aligned, as resulted from the previous section. This session is a good example, and players should see the advantages that will justify their investment efforts. Now, IT technology needs to be broadly used. This is a good opportunity to produce digital transformation in health. Our colleague from Denmark was saying, well, Denmark reality and the Nordic country reality has nothing to do with us. They can provide data on survival after cardiac surgery till the end of life of patients, because no one escapes. Here, no one registers, or not a lot of people are registering, so it's difficult. Now, health equity needs to be preserved, namely by integrated models of care and transparent outcome reporting. Innovation should be incentivized as the way to improve outcomes and to create value. So this should not deter us from innovating. And providers at large, medical and nursing providers in particular, need to be value advocates, get engaged in customized value projects and outcome-linked payment schemes. I think insurance companies here are probably the new healthcare breaths that we, healthcare system breaths that we perspiring in the air could be a way to move in this direction, because these things really cost a lot of money and take a lot of stuff, and it's really needed that private hospitals and public hospitals will give the money and the people and not only be focused on immediate profit and volume production. Now, the title of the session is both sexual and pertinent, projecting the future. The speakers were carefully selected not only for their competence, but for covering the whole spectrum of stakeholders that might lead the transformation. Doctors, managers, innovators, service providers, pharma, all of them are experts and will bring their experience in the field in order to help us shaping the future of value-based healthcare in Portugal. I would like to thank Health Cluster, and the leadership is here, for putting up yet another meeting, and for inviting me to chair this table, and for your recognized leading entrepreneurship in the field of value-based healthcare in Portugal. By the end, Joana Feijó from Healthcare will summarize the session in a white paper. I will now call each speaker in sequence for their, as they say here, 6 to 8 minutes address. Thank you. So, first one, Nuno Alves.
You can do it by here.
Yeah, absolutely, whatever you like. So, Nuno Alves is an ophthalmologist from Hospital CUF Descobertas and Centro Hospitalar de Lisboa Central, my hospital.
Good afternoon to you all. And first of all, thank you for the invitation. I wasn't expecting to do a monologue, but it's okay. We can discuss it. Well, I can discuss, as I'm a doctor, I can discuss the clinical part of this ecosystem, and more precisely in the program that we've been working for the past 5 years, that is the VHP Portugal Cataract Program. One of the major struggles that you have to overcome is data flow. And VBH exists whenever there's data. No data, there is no VBH. And if you believe that this is the future, and the mindset of healthcare will be based on VBH, we need a steady data flow. And for that, we need patients and doctors. And doctors have to have time to do this recording. And as a doctor and a medical leader for this program in my unit, one of the major problems is to get doctors engaged and keep them engaged throughout the project, and bringing more doctors to the program. Because whenever I ask doctors, hey, why don't you come up and be part of that? They already know that we'll have to invest time that they don't have. And we need time. We need time to talk with the patients. We need time to think and study and be accurate on the diagnosis. We need time to plan in advance our surgery, to do a flawless surgery with the lowest complication rate. And our patient health experience is linked to that. And we do know that outcomes are results versus expectations. So it's important to talk with patients, okay? And we've been talking throughout the day about IT. I think it's fundamental to get better IT, but we have to deploy it faster in the units we perform surgery. And we are running VHP programs because doctors are spending too much time in clinical recording, and we don't mind, in general, doctors don't mind to be under the microscope. They're used to it. They don't mind for their results to be evaluated, but they do mind with paperwork overload and clinical recording. So IT will be fundamental, but we have to be faster on doing that, or else it will run out of time. And until then, until IT or AI in the future help doctors with this burden, maybe we have to recruit more personnel, and there is staff. You had a tremendous staff to collect 50 years of data throughout these 50 years. So we need staff to help doctors to deal with this burden of data collection and data flow, and to let them do what they do better, to be doctors and come up with good results. We should never forget that VBH is measurement, audit, analyze that data, but to promote cycles of improvement. The idea is to get better. Without that, we will stall.
Yeah, if I'm allowed in this condition of mind before passing the words on, I think I can summarize what Nuno just said. Basically, we need staff to do this, and we need allocated staff to do this. And if we don't have that, it will not work. Special programs in unit normally live of a coordinator. Transplant programs live on a transplant coordinator. Fast-tracking programs on a fast-tracking coordinator. So we need to have someone, because doctors really are in the fuss of their work, and they are being pressured every day for volume production, and that's all. So if I may summarize, you'd say that you need staff, you need resources other than doctors to implement that. Is that right, Nuno?
That's crucial.
Okay, good. Now, sorry. So next one, it will be Dr. Felipe Costa, Director of Value-Based Health Care, Luz Saúde.
So thank you very much, and thank you for the invitation, Health Cluster, and compliments to my dear fellows here. It's always a privilege to be here, sharing our experience and the things that we have been doing. So the history is back to 10 years ago when we started doing value-based healthcare and researching and developing and looking for the future of the implementation of value-based healthcare. And this created us to the first moment and the first statement. So what's the mission of adopting a value-based healthcare statement in our country, in our organizations? So what's the purpose? And the purpose is to deliver best outcomes for the patient at the correct costs. So if we are not measuring outcomes and costs, we are not doing value-based healthcare. That's the first thing. Secondly, it's important, and when we are creating an IPU and looking for the part of the pathology, because we have to get back to what was the basic model of Porter, because it's the one that talked about it in the beginning, and I had lucky to learn with him back in Harvard. And the thing is, yeah, when we are looking to an IPU, are we really creating an IPU? Or what is been struggling to create an IPU? Because everyone knows the struggling about implementing value-based healthcare. And so the first thing that we went for a huge research and a huge development, it's called culture organization, because that's the big issue on value-based healthcare. And no one, or few are talking about, I know that Sally is doing that thing because, yeah, that's the problem. No one is talking that creating a value-based healthcare model needs to change and will change dramatically the culture organization of the system. Not only on the institutions, not only in the relationship with doctors and nurses and practitioners with their patients, but secondly, putting the patient on the center of the equation. And that's what we have done. More than 50% of the results for taking up decision comes from our patients. That's a purpose when we create value-based healthcare. So more than 50% of the results comes directly for the patient. And then we analyze every outcomes and every cost with the less burden for the whole team. That's another purpose. Looking for the people that are doing what is contributing to have the evidence. Because having data, and I learned and I heard about everything that you've been talking about today, and I hear resources, I hear more burden, but what about helping the system to be much more clean? That everyone is already producing a lot of data, but are not producing information. 80% of the data is unstructured. This is the reality. So let's talk about reality and not about theory. And that was the mission when we started the program of value-based healthcare. Let's put it in practice. Let's put it in our mission. And I was able of having, concerning our mission and our purpose, to create 4 models, very important. Trustful, shared consciousness, empowered execution, and common purpose to really deliver better outcomes for the patient at the correct costs. Because I've been hearing about reduction, about costs, but I will share and I will say to everyone that is doing value-based healthcare, are you sure that you're going to reduce the costs? On an unpaid system that you don't have enough value that you're creating, probably you have to enlarge the payments. Probably you have to enlarge the cost to deliver better outcomes. So only when you're really measuring, you can really analyze one big problem that is creating on value-based healthcare. It's called variation. Variation of behavior that creates variability of outcomes. And that's the work that we have with 8 years of data. Now we are in a moment that we create an improvement cycle of transformation with all our teams, capability and time for them to look to the data and to improve the things that they have been doing. Because another purpose of creating value-based healthcare is to give time for improvements. And then you can be prepared to talk about the ecosystem and the sustainability of the ecosystem. And from the first beginning moment, we had a vision to create a more balanced and sustainable ecosystem with the providers, with the suppliers, with the financial guys, from the moment zero. So this is our purpose from the beginning, our mission, and I will not develop more about this, but we can talk specifically about each of the components. But this is the statement 10 years ago. Now we have more than 40 pathologies working around, but we have to give time. We have to look for the evidence of what you're producing, and I never found on evidence what was being said on perception in the first meeting that I had. They were the greatest. But once we measured, they were not the greatest. But we have to give them time. Give time to improve, and I'm seeing a lot of faces saying yes, yes, yes. But only with this evidence and with this time, we can now talk about looking for that and talking with the model of payment, sustainability, and everything. And the thing is, we need evidence, not perceptions. Okay?
Okay, if I may, I will follow this process, if you like, because it helps us to cement what. So basically, Philippe, you mentioned 2 things that I think are really important. One is culture, organizational culture, and the culture to be evaluated and to measure what you're doing. And I think probably this is one of the reasons why value-based healthcare is not so well advanced in our country. And basically, culture takes a long time to implement. And, you have to do it not by meetings, but by doing and generating, someone was saying before, trust and feedback. Because if people don't get motivated because they feel what they're doing creates value, they will not do it. The other thing you mentioned, and I think it should be emphasized, is meaningful information. And you said something very rightly. Now, data is not information. So you have to process, and sometimes people entertain themselves in collecting a lot of data. But we don't need a lot of data. We need relevant and significant data. And this is another obstacle for value-based healthcare or any other data registry, which is academic registries, which get everything of everything, and then they just got nothing in the analysis. So I will take from your presentation, from your conversation, that culture and meaningful data are important, right? Okay. Now, following Vanessa Ribeiro. Oh, we have the public system here. Head of Planning and Innovation from ACHSS. ACSS.
Thank you. Hello, everyone. Good afternoon. And thank you for inviting ACSS for these forums. I think it is always important to be part of the discussion. So thank you once again. I want to build up on what has been said, but first of all, and I know if I don't say this, someone is going to ask for, so I'm going to start for this part, and then I'm going to build up on what has been said here. So the first thing that I'm going to pick up is the value-based payment models. That has been said over the day, that is an important incentive for providing value-based healthcare. And in the public, in the National Health Service, we are already doing this kind of payments. And there are two kinds of these payments that incentivize value-based care. One of them is the bundle payments. We have bundle payments for several conditions, such as breast cancer, HIV, pulmonary cancer, the treatment of obesity, and several of them. The future, that is the topic, the title of this session, projecting the future. So what we need to do for the future, it's not to implement a new value-based payment model, but it's to refine what we have right now. And to refine it, I think what we need to do is to associate the outcomes to the payment to the model of payment we have. Another value-based payment model is capitation. We have now 10% of the population covered by local health units, as you know, or some of you might know. And this year, there are going to be much more of these local health units that are units where primary care is integrated with healthcare. And these organizational models, these institutions, are paid by capitation. And capitation models are payments that incentivize providers to take more actions on promotion and prevention, promotion of care and prevention of disease. And of course, this is value. Value in an overall perspective, not related to a disease, but the overall health of the population. So I'm done with the payment models, and now I want to talk about the organizational change that we need to do to move forward on value-based healthcare. So nowadays, hospitals are used to work alone inside the four walls. Primary care, the same. And they don't connect to each other. So this is one of the aspects of the organizational change that I think we need to move forward. And to define these clinical pathways, we should not do this just on the hospital level. We need to do it across all the patient journey, as in the previous session was said. And also, this means, of course, involving several professionals, doctors, nurses, administrative professionals, having professionals to help to register the data and analyze the data. And there is one more piece important in this puzzle, it is the patient. So to do these clinical pathways, we need to involve the patient, and we need to measure the patient, the outcomes that are important to the patient. So, and I think that's it.
Okay. Now I'm getting on you. Now, basically, what you have been discussing, it's not paying based on quality or based on the value you create to society. There is no way I have in my unit, and I work in a public unit, I also work privately, as everybody knows, but in my public unit, I cannot pay a surgeon better because his mortality is lower. Now, I can prevent that surgeon to operate if the mortality is higher. And I have done, and I have done that. Well, that's why I have so many friends. No, and I have done that. But I cannot pay a surgeon because he is better or because he goes there on Sundays. I create a classification for surgeons in which I gave 5 points for technical efficacy and safety, 3 points for publications, and 2 for being available on Saturdays and Sundays. And you know, I have them graded, but I cannot pay them differently. I cannot either hire or fire them. So the system is blocked. Now, anyway, I will share with you one interesting thing, which is a social professional case, which I shared with a couple of ministers of health without any practical results. Now, we have a program for surgeries, for additional CGIC, which is something Minister of Health created to help on waiting lists. And we have them on Saturdays. And they start, well, normally the working time is 8:30, as you know, till 8 in the evening. Well, they start around 7:30. And around 3 in the afternoon, they have 2 cases, clean cases done, and everybody's back home. Well, on the weekdays, it extends till 8, and sometimes we have to redo what we have done in the morning. So what I'm trying to say is that I think we all know what we need to do. We need to be able, in the public system, to compensate people, not only for volume, and we have different examples. Transplantation services, they are paid with incentives. If they do a lung transplant, they get 2,000 or 3,000 euros. That's good, you know? But that's not because the transplants are better. It's because it is yet another transplant. So I think we really have a long way to go in order to be able to compensate people by paying, which is what everybody is expecting, because what you do is better than. Would you agree with me?
I would prefer to pay for the prevention of the cardiac surgeries.
Because that's easier, but it's not truly value-based healthcare.
It is.
Okay.
It is.
Well, it is a bit. It is a bit. It is a bit. Now, I will call now Professor Helena Canhão, which is a project leader and clinical director, among many other things, for the Patient Innovation Association. Helena.
Thank you so much. Thank you for the invitation. And it's really a pleasure to hear you. And I do not agree with you, Flip, in some things, and I would like to elaborate, because I think one of the problems here is to know we know what to do, but not how to do it, how to monetize, and what is the cost of, or what is the value of the healthcare. And this is the problem, because we know, and as you said, we need to compensate surgeons, for instance, for
doctors, rheumatologists,
and everyone for the good, but we don't know how to value it, because it's really simple to know the price of a surgery, the price of an appointment, and we need to change the minds, we need to change the organizations, but we need to have the tools, and now it's really difficult to know how to compensate, because we don't have a complication after the surgery. And this is the point, and this is a problem. Also, one of the other problem is the fragmentation, and there are lots of different initiatives, different activities. You mentioned some of the examples. We know that there is now some KPIs for the healthcare for the GPs, the primary care practitioners. We know that for some pathologies, rheumatologists, we can compensate because some of the patients achieve the best results. But in fact, these different initiatives are very different. And I'm here with different hats. So one of them is as a rheumatologist and a former president of the Portuguese Society of Rheumatologists. And we have a national registry, the Reuma PT, is a national registry for patients and for rheumatic diseases. And here, this is really national. We cover more than 90% of the centers, the rheumatologists, the patients have access, and they can put the information there. We measure the outcomes, we measure the disease activity, we know the effects of the different drugs, but until now, it's not used by the national authorities for measure the different and reimburse the different drugs. And we have the tools. In this case, we have structured data, we have the proper information, but it's not used by the authorities. When I put the hat of the responsible for clinical service in our hospitals, what I'm asked for is to say for the next year what will be the number of appointments, what will be the length of time that I should do, or what is the number of first appointments and second appointments, and we do this relation. And this is easy to value, but they don't ask me, how is your rheumatoid arthritis patient? What is the disease activity? What is the satisfaction? And I have this data in my service because I have the register. So I think there is. We need to change the mind, we need to have different organizations, but what we need is to collect all this information and put everyone working together, because even when we have the tools and the initiatives, they are so fragmented and they are not gathered and used by the different stakeholders. And just for finish this first part, one of the other hats is I'm dean of one of the medical schools, and I think we need to starting to educate the new doctors, the new health professional about this criteria. But when we do this education, we can do it by theory and explain what is the value-based healthcare. But in practice, we don't have the examples to show them, and this is really important. And we need to starting to look for the future generations and started to change their minds, because they will be the future, and we need to start by showing the examples and have this with the health and the education ministers.
So Elena, if I can summarize doing the same, which I think is useful. So data exists in some areas. I would say data does not exist in a spread, but there are registries out there. There are registries for cardiac surgery also. There are for rheumatology, as we learned. Now, but the emphasis is not in quality, is not in outcomes. The emphasis is what the hospital administration comes from, when it comes from the health ministry, is how many cases are you going to do next year. So what we have here is an excessive emphasis on volume production, and that deters us from looking to what is essential. Basically, quality of care can nowadays be measured very accurately. Risk-adjusted mortality and complications adjusted for complexity in cardiac surgery that I know well are very precise. So I think for rheumatology, you have functional indexes. So I think we have to make this shift, and the authorities will have to help, because someone is to be at the wheel, someone should lead. Now, the final message, which probably is most important, is about passing this culture on to our students. And again, I agree with you that if we don't have good examples, the same for patient safety and medical error. We teach medical error in the university initially and by the end of the medical course, because that's where you get sensitized to that. So I think really medical schools, and you are in a very good position now, should make an effort to, I know through Express, of course, should make a good effort in order to instill this in our students. Now, thank you very much. We will pass on to Salome Azevedo, which is representing the collab, right? Okay,
yes. So if I say something wrong, Ana Rita is not here, and I'm representing her.
Well, I will tell her. I will tell her.
I think the only way to make a good contribution in this panel full of professionals working in the area is coming from the research part. So forgive me if I'm going to be very pessimistic about it, but I'm finishing my PhD, and my thesis is on value. So my question to you all is, what is value? And I don't think that we are all going to agree in the same definition if we ask everyone to text me and saying that. So based on that, the first problem that we are facing in research is actually figuring out what is in the head of every person considering value, and value in healthcare too. So concerning that and putting that into practice in research, we actually don't have a lot of methods and methodologies to deal with these different perspectives on value also. So most of the work that research, so academics are trying to come up with, is to struggle and to pace forward to the practical approach to understand how to collect these preferences from so many different stakeholders in order to reach the value that it's promised in healthcare. Also, again, compared to America and Portugal, we live in a solidarity healthcare system, so we must provide care to everyone. And basically, just if we think in a systems thinking perspective, it's not going to be in an optimal cost, for sure, right? Because there are patients that need more than other patients. How value-based healthcare deals with that? And of course, this is my perspective, again, in research, not in a practitioner way, because definitely it's different. So I'm the one putting in here, let's go and see. Imagine that we have all resources, how we can do this, right? What are the methodologies to capture these preferences, either from the payers, either from the patients, either from the healthcare providers, and the professionals also, without even saying that someone in here is trying to make more money than others. Just like forget about that, forget about the corruption. Imagine that we are doing a game, and we can implement value-based healthcare in Europe, in more particular in Portugal, and everyone is very good people, okay? So no one has bad thoughts. How can you do it? Actually, you don't have the methods. A lot of academics in operations research, in management science, are trying to come up with participatory methods that can put the patient in the center. Because saying putting patient in the center, for me, it becomes really hard to understand. And I'm very pragmatic, okay? So I'm trying to, like, when someone says, let's do this, when Professor Fregata says, let's put the patient in the center and try to come up with results. You say that, and you did. But how we do that? So, like, should we call our, like, Professor Fregata patients and put it in the office and say, what are the outcomes that you want to achieve? They don't know. What are the outcomes they want to achieve? I had the opportunity to work with Professor Elena back in rheumatology. It's even worse because her patients don't know not even how to express their symptoms. Imagine that expressing their outcomes or the results that they want to achieve. So I want to be teasing in here, and again, that's not my name in the list, so if you don't tell Ana Rita, it's okay. But our work in the lab is actually to understand and explore participatory approaches to put these new stakeholders, patients, payers in the center, actually not in the office, working together and understand if they know what is value. And just to finish, a last topic is actually like from an anthropologist. And I really liked the way that he expressed the meaning of value. He tried to come up like since the economic theory, so go again from the Greeks. But he says in one thing, okay, so the management consultant people came up and said that value is the new world for everyone, right? Let's use it, but let's discuss it and let's define it in a proper way that we can operate it and use it in a way. So it's,
Thank you, Salome. Well, I'm not sure whether this public assumption that studying for your PhD and not knowing what value is, being the PhD on value will help you. But anyway, because even your name is not there, so we will go on. Now, you tackle on three aspects I would like to underline in the same line. So, and we're having a good fun and time here, really. So, so, as you say, this concept was born in the United States. And medicine in the United States is totally different approach from this. Medicine in this part of the world, fortunately, has got sort of protection social cover, which is good. And this brings us to a new dimension of value, which is the one driven by Muir Gray from Oxford, an old professor, which is applied to this part of the world, which creates another dimension with the allocative dimension, which is the same, are we providing care to the ones we need? And then that is linked to another definition that you mentioned, which is equity. Are we providing different people things that leverage the needs of which are, of course, need to be individualized? So the question is, we don't need to stick to the American value. We have a public dimension for this. Are people in Trás-os-Montes having the same access to magnetic resonance imaging and the quality? I tell you something that you will hear about soon. CoLab made a study about healthcare variation in this country, and for the single reason that living in one geographical area of this country will affect your risk of dying and staying longer in hospital for 2 or 3 times. So these are real figures. It will be soon published. Now, finally, patient in the center. Hang on a second, just finished. Patient in the center. Well, patient in the center is like leadership or sustainability. It's a good word. It's a nice word. Now, normally, some years ago, people were saying, let us empower patients. Well, I normally said, let us empower professionals, because professionals need to be empowered. Now, this thing of patient in the center reminds me of that gentleman with prostate cancer that went to the urologic surgeon and said, well, we have a list here. We have brachytherapy, conventional surgery, robotic surgery, and doing nothing. What you want? Well, I don't want to have the prostatic cancer. So basically, putting the patient in the center implies that the patients need to be well informed. And that is, again, another dimension of value-based healthcare. So to summarize what you said, it's equity and allocation and patient in the center with care, right? Okay, Rocha.
So thank you. Actually, the worst thing of being the last one is actually trying to carve something out which has not already been said. But, I would start with one thing. Over my years of working in Portugal, I've seen a lot of initiatives on value-based healthcare. Starting, I actually participated in the first ever discussion with Professor Porter back in, almost 12 years or so here in Portugal. And I think one of the points that he really mentioned is that there is not the value-based healthcare stems from value-based competition originally. So it means that if there is not a publicly available data by which we agree to compete against, there is no process by which we can create this cycle of improvements. And for that capacity, I think actually being a public system in Portugal, the government has a very peculiar and particular place in to play this role. And I would say that for me, government has, we've heard a lot on standardization, on very key elements, but I think the government needs to have at least 3 things very clear. The first one is clarity, because in complex systems like this one, it's very easy to get entangled with very difficult concepts. So we need to be very clear on which are the areas that we are going to prioritize. And the elicitation process needs to be very clear. So meaning I'm going to tackle these specific areas, and I'm choosing those areas by which we are going to really move forward in a very clear process using multi-criteria analysis or whatever. But it's a way by which we can bring different stakeholders together on a common framework to discuss what we are going to prioritize. And that has not been done. Also, another element of clarity is that we don't allow that people and the various stakeholders say this is value-based healthcare of things that they are not. And actually, meaning, for instance, I cannot also bring to the table, changes in the healthcare system or reforms, and disguising them as value-based healthcare things which are not. And I've heard some of them today. So we have to be very clear on those areas. For instance, I'll give you an example. The devil is always in the details. For instance, bundle care or capitation can be either, if very well designed, can be value-based, we can call them very well value-based healthcare as long as we keep the patient-reported outcomes there, ticking, or it can be just a cost containment exercise. It's very easy to disguise those two things within the same concept. One of the, for instance, capitation, if done wrong, can actually, and it was not weighted by outcomes, it really can lead to care deprivation, which is actually quite the contrary or the opposite that we do. So, and these are probably one of the key points. The role of the government in here, it's very important, and not just a specific executive, because, and that's the second element, is a sense of urgency, but also patience. Urgency because we are already late. We have to have this thing moving very fast, but at the same time, be patient because results will take time. I've heard, for instance, things like, we're going to put in an initiative measuring costs and value for a specific disease, and at the same time, I'm going to implement reforms, which basically, it's like in the middle of the run, we're actually changing things. So I think there needs to be some time to watch, observe, stabilize the data, and then upon those data, actually have the professionals use these, because professionals who are really, identified with this will understand that this is those data is actually for their improvement and their improvement of their patient base, and that's so the constant. You just watch, observe, report, having more people and feedback. Not only between professionals, but between institutions, and this inevitably will lead to circles of innovation and circles of improvement. But if we do it at the same, for instance, ULS, I'm probably saying something which is not politically correct, but we haven't analyzed yet exactly, actually, the learnings fully from the ULS, and we're bringing them here. I'm not opposing that, but I think at least we should look into those areas and see in those specific areas where are the improvements that we want to look upon. For instance, let's pick one ULS and see if there is already this kind of understanding that from this specific cycle of care, this in the previous ULSs, this has already been integrated and is generating information. In my opinion, I haven't seen too much of it, so I think this is one of very key element. And lastly, I think patient-reported outcomes. We actually heard about many criteria and many KPIs being discussed here, but I think the key element is patient-reported outcomes, actually preferably collected on a very regular basis. And I would, ideally, the best thing to happen is that I would have access, I as a medical practitioner, will have access to the full cycle of care of one specific patient, the immediate time that we can consider that cycle has been completed. Because then, and it's not just kind of a cut and slice, twice a year or 3 times a year, but on a steady flow. That would be, a constant and immediate feedback at the patient level. That's, probably too much, but there's
Okay, Luis, if I may summarize, we have 2 minutes or 3. I think basically you mentioned clarity, and this really links to what Salome said. And maybe there is some confusion in the concept of value-based healthcare, and the way Michael Porter defined it is a simple equation in which in the numerator you have outcomes as also as perceived by patients, and not immediate outcomes in one episode, long-lasting outcomes. I normally say I don't care if I do coronary surgery or if patients get stents, because I'm paying that care as a taxpayer. What I really care is how many of those patients are with their grandkids or playing golf 5 years later. So that takes time, as you said. So clarity, and in the dominator, you have the final total costs to achieve those same results. It's something the industry knows very, very well. Now, the other thing you said is to be open-minded. And I don't think we are in a country that is very open-minded. You mentioned the example of comparing the types of ULS, and you're still thinking A, B, or C, which one is best. You have the example of the public-private partnerships for hospitals, and political decision went totally averse from what has been found. Well, I'm getting incorrect now, so we'll finish this. That's okay. I think it's better now. Yes. Use the microphone, please.
One of the points that I think the government can also really push this forward is really, if we cannot start incentivizing by output, by patient-reported outcomes, at least we can start incentivizing by participation in generating data. Meaning, incentivizing, different hospitals and different institutions just for the fact that this group is willing to start generating data.
You take, yeah, okay.
How can you value patient satisfaction? For instance, what will be the methods? And using the arguments that Salome said before, what will be the methodology, and how can you value the patient satisfaction or the patient doing, for instance, activities with their sons and daughters and things like that? I think this is difficult, and this is the problem.
You can ask. You can ask them by inquiry, and that is available. Although we should value that in the right measure, patient is not concerned with the value of his own creatinine. He's really wondering whether the doctor was pleasant, if he had not to wait long time, and things like that. So, I mean, putting the patient in the center, it's very nice for politicians, but we have to make sure that that should be valued, appropriately. You are asking how can you push people to register data. The United States found it out very well. And a cardiac surgical department that does not provide data to STS is not graded as a quality center, is not listed as a trustable center, and eventually is not funded. So basically, I give you a tip to Fernando Araújo if you want. You may tell him from my part that he can eventually invite services in the country to supply data to a national registry database, and if they not, you take them 15 or 20% of the funding mechanism, and that will be perfect. Okay, well, I think we should finish, right? Okay, Joanna. Well, I wish to thank you all, and I think we had a lot of fun. Thank you very much.